Do you guys remember what we discussed in my last video? Let's take a look, shall we? We started a series on oral premalignant lesions, and we talked about leukoplakia in much detail. Today we'll be talking about erythroplakia, which is quite similar to leukoplakia, but there are some differences. Erythro means red and plakia is patch. So it is a red patch or plaque which cannot be clinically or pathologically defined as any other lesion. So it is a fiery red, sharply demarcated lesion situated at a slightly lower level than the surrounding mucosa. Because it is at a slightly lower level than the surrounding mucosa, this is going to help distinguish erythroplakia from other red lesions of the oral mucosa. For example, the lichen planus, which is limited to the surface of the oral mucosa. It usually affects the older population between 65 years and 74. It has no specific gender predilection, meaning it can occur to either older women or men. It has the highest risk of malignant transformation, so more than half of erythroplakic lesions turn out to be malignant. In erythroplakia, the dysplasia may vary from mild, moderate, severe, and may even progress to carcinoma in situ. Dysplasia is the presence of abnormal cells within a tissue or an organ. Carcinoma in situ is when there is severe dysplasia and it covers the entire thickness of the epithelium, but the basement membrane is going to be intact. As we can see, this is the normal epithelium. In carcinoma in situ, the entire epithelium is going to be covered, but this basement membrane is going to remain intact. Now, what is it going to look like clinically? It is a well-demarcated erythematous plaque or patch with soft velvety texture. In some parts of India, people have the habit of reverse smoking. So, Palate has seen to be commonly associated with erythroplakia. In some studies, it tells us that the retromolar region are most commonly affected in females, while the floor of the mouth in males. There is no specific reason as to why this happens. Sometimes it may be associated with leukoplakia. Now it will be known as erythroleukoplakia or speckle leukoplakia. As we can see in this picture, both the white and red lesions are coexisting. It may measure between 1 to 4 centimeters, as small as 1.5 and as large as 4 centimeters. It is usually asymptomatic, meaning it may go unnoticed for a quite longer period of time. Some of the important etiological factors which may be involved with erythroplakia are tobacco smoking, smokeless tobacco, and alcohol. These are definitely associated with erythroplakia. Betel quid pan, tumor suppressor genes are also associated. Now, the candidal infection and the viral infections, both these are secondary or superimposed infections, meaning that if a patient has erythroplakia, there is a 50% chance that he can be superimposed with this viral infection or candidal infections. Now, we're going to see how tumor suppressor gene plays its role. P53 gene. This is located on the chromosome 17p. So, if there is mutation taking place in the P53 gene, the normal suppression of the cells is not going to occur. That is going to be inactivated. Now, there is going to be uncontrolled cell division, and that is eventually going to lead to a malignant transformation. Now, let's look at the histopathological features. In the histopathology, we are going to see moderate or severe dysplasia. Some dysplastic features include an increased nuclear to cytoplasmic ratio, meaning that the nucleus size is going to be bigger as compared to the cytoplasm. There's going to be darkly stained nuclei, hyperchromatic nuclei, and there's going to be an increased mitotic activity, meaning more cell division. The vasculature in the connective tissue is going to appear to be more prominent, and the main reason for this is that there may be a decrease in the keratin production. So the vasculature is going to appear more prominent, and As we know, inflammation causes redness. So that is also a cause for it to appear more red. The main reason for the decrease in the keratin production is that there is a failure of epithelial cells to undergo complete differentiation and maturation to the point of keratinization. We're going to see that the epithelial cells are poorly differentiated, which is going to cause the epithelium to appear more translucent, and eventually it's going to look more thinned out, atrophic. In the microscopic slide, we can see that there's a lack of keratin layer. We will also see some chronic inflammatory cells. Now we're going to see how we're going to go towards treating an erythroplakic lesion. After observing an erythroplakic lesion for around 2 weeks, we are going to carry out biopsy. So we are going to carry out biopsy and evaluate that piece of specimen under the microscope and determine the dysplasia. If there is no or mild dysplasia, we're not going to carry out any intervention. We're going to discontinue any carcinogenic habits and advise the patient for a follow-up for every 6 months. But if there is moderate or severe dysplasia, we're going to have to go through maybe a surgical excision. We're going to achieve clean margins. Electrocautery may be done. Heated electrode is applied to the lesion to achieve hemostasis or tissue destruction. Similarly, we can use cryosurgery, meaning extremely cold temperatures may be used, like liquid nitrogen or carbon dioxide can be used to cause tissue destruction. And lastly, we may also use laser ablation. Laser ablation can be used to achieve good clean margins around the lesion. So guys, this was everything about erythroplakia. Keep watching my videos for more oral premalignant lesions.